PSA castrate patient. And before I get started, I want to thank the presenters of these studies at the ASCO meetings for sharing their slides with you, because I'm largely going to share with you the things that were presented at the national meetings this year. These are my disclosures. And by way of introduction, castration-resistant prostate cancer is defined as prostate cancer progressing in the presence of a castrate testosterone level, typically due to orchiectomy or more commonly LHRH agonist therapy. There is a large spectrum of that disease, and what this first talk is focused on is the longest duration of survival, the biochemical-only M0 patients. So by definition, these are patients in whom hormone therapy was started early, either in the adjuvant setting, and they've had a recurrence while continuing therapy, or for a rising PSA following radiation or surgery for localized disease. And now these patients are progressing despite hormonal therapy. Historically, there's not been any standards of care for these patients, and it's been quite frustrating to take care of them. And by historically, I mean up until last June, so not too long ago. We know that second-line hormone therapies of various sorts, the classic anti-androgens, ketoconazole estrogens, and even conventional glucocorticoid steroids have some activity in this disease, as evidenced by PSA reductions. Typically, responses are not very durable, and there's not been any studies that have shown a long-term meaningful clinical benefit to these kinds of interventions. Now, I don't have time to show you all the data from these failed randomized trials, but there have been a number of efforts to modify the natural history of this pre-metastatic state, if you will, primarily with bone-directed therapies like zoledronic acid and the endothelin antagonists, and most recently with denosumab. Denosumab was the first agent to actually show a metastasis-free survival advantage. At the median, it was 4 months. There was no associated overall survival advantage, and the difference was not judged to be sufficiently compelling to recommend it for routine care or for regulatory approval. We did learn from these studies, though, that there is a definable natural history of a rising PSA castrate patient, and one can identify various risk groups. And this has been very useful both for counseling patients and also for clinical trial design and execution. So if you look at the time to bone metastases or death, and obviously most of these are bone metastases events, the absolute value of the PSA at the starting point, and most importantly, the PSA doubling time, are very strong predictors of outcome, with PSA doubling times less than 6 months identifying the highest risk group. You can see here that the median time to metastases in that high-risk group is a little over a year. This is another way of looking at it. The importance of PSA doubling time is plotted here. PSA doubling time is plotted against the relative risk of metastases or death, and you can see that as you cross the 8-month threshold, you have a rapid increase in the risk of metastases or death. So there seems to be kind of a breaking point around a PSA doubling time of 6 to 10 months, beginning to identify a higher risk group. Now, there's a strong rationale for pursuing hormonal therapy in castration-resistant disease. We know that now from metastatic disease, but this work really began with the understanding that androgen receptor signaling is alive and well in castration-resistant disease. And when this was first described by Bruce Montgomery some time ago now, this was an important discovery. So we know that the AR is expressed, is active, and is producing the products of AR signaling, such as PSA, in the metastatic lesions in a castrate state. So this year we saw the presentation and recently the publication of 2 landmark clinical trials that evaluated the novel AR signaling inhibitors apalutamide and enzalutamide in this setting with the goal of demonstrating a metastasis-free survival benefit. The first of the two trials I'm going to discuss is the Spartan trial. This was a placebo-controlled trial in non-metastatic CRPC, and these trials are placebo-controlled because, as I mentioned earlier, there's not a standard of care that's well established. I hope you can see the details. The font's a little bit small here, but the trial did allow low volume pelvic lymph nodes. Patients continued on their standard hormone therapy. They were stratified by PSA doubling time, less than 6 months or greater than 6 months. But they had to have a PSA doubling time of less than 10 months to participate. In order to see these events, we really wanted to focus on the higher risk patients. 2-to-1 randomization to apalutamide or placebo with continued hormonal therapy. Metastasis-free survival was the primary endpoint. There is a second progression endpoint as well as a variety of other endpoints. The trial was published in the New England Journal simultaneously with its presentation at ASCO. So primary endpoint MFS, there's a whole host of secondary endpoints. Importantly, the time to symptomatic progression was reported, as well as overall survival. This is a summary of the patient population. You're going to see that the two trials I'm going to talk about had very similar patients, median age of 74 years. These are patients who've survived for a median of 8 years since diagnosis, living with their prostate cancer, going through local therapy, relapse therapy. Median PSA doubling time was 4.5 months, and I want to really focus our attention on that. These were truly high-risk patients. 71% of them had a PSA doubling time less than 6 months. That is not the average patient that we necessarily see in practice. When I see these patients, there is a full spectrum of them, and some look like this, but quite a few have a slower PSA doubling time. Why is that relevant? 17% of them did have pelvic lymph nodes. This is the primary endpoint, and a very significant result, a 72% reduction in the risk of metastases or death. The median MFS for the placebo was 16 months, which is roughly what you would have predicted from those curves that I showed you at the beginning of the talk. For apalutamide treated patients, it was estimated at 40 months. Haven't really reached it yet, so this number may shift a little bit as more data comes in with longer follow-up, but a clear difference, hazard ratio of 0.28, and I think most people would view this as a clinically meaningful magnitude of delaying metastases or death. What is going on here? There we go. When looking at the various subgroups, this is the obligatory forest plot, and the message here really is that directionally the benefit was seen across all the subgroups. When you look at these things, you expect the confidence intervals to cross 1 at times because there's not sufficient power to look at each group statistically independently, but you're really just looking for direction, and we don't see any evidence that there was heterogeneity in terms of delaying metastases or death. This is progression-free survival, which is really the same thing, except death is treated differently. This is, I think, a more interesting endpoint, which is time to symptomatic progression. So this is looking at skeletal-related events, pain, worsening symptoms, or clinically significant symptoms requiring intervention. I think that's important because one of the criticisms of these kinds of studies is that you're subjecting patients to a drug that has side effects. These patients are not symptomatic from their cancer. They don't have metastases. So are you really making a difference, or are you just delaying a single rib met that's asymptomatic? And you can see that while the difference on the hazard ratio is not quite as large, it's not 0.28, it's 0.45, there's a clear and substantial difference in symptomatic progression with treatment. Overall survival is not mature. Most of these patients are still alive. The hazard ratio is 0.7. The p-value at this point is not statistically significant. This is a look at patient-reported outcomes and quality of life. Pretty hard endpoint to look at in this patient population. These patients are, by definition, symptomatic only really from their treatment, because you don't get Mets, you don't have Mets, so you don't have cancer-related symptoms. They may have symptoms related to complications of their radiation or prostatectomy. They may have symptoms related to their ongoing hormonal therapy. So all you can really conclude from this is that the quality of life was pretty similar in both groups, and this data is used to make the case that the side effects weren't too bad. I don't know that this is a highly sensitive way of looking at side effects, but the overall message is that quality of life appears similar across both groups. Adverse events were more common in the apalutamide arm than in the placebo group. Serious adverse events were fairly similar. Adverse events leading to discontinuation of therapy, 11% versus 7%. This is a little bit more detail on these side effects, and these are really what you expect with this class of agents. They're quite similar to what we're accustomed to with enzalutamide, which has been on the market for some time. Fatigue is more common. Weight loss is more common. Arthralgia, falls are more common. So folks who are frail and at risk of falls, something to think about with these drugs. A couple of things that are a little unusual for those of us who prescribe enzalutamide routinely is the skin rash in 23-24% of patients, and hypothyroidism in 8% of patients. These appear to be relatively unique to apalutamide. These side effects have been reported to enzalutamide, but not nearly as commonly. Seizure, which is a concern for this class of drugs, was very uncommon, 0.2% of patients. Now, roughly at the same time, enzalutamide, the other modern high-potency androgen receptor antagonist, was studied in a very similarly designed PROSPER clinical trial. Again, almost identical, really designed here. Metastasis-free survival was the primary endpoint. This trial got a little bit of a later start. The data are not quite as mature. Was presented at the same meeting, was just published in the New England Journal, I think, in the last 2 weeks. These are the baseline characteristics, 1,400 patients. Again, you can see median age 74. It's almost identical to what I showed you. Median PSA of between 10 and 11. Median PSA doubling time even shorter, 3.8 months. So these are also high-risk patients. The adverse event list is really quite familiar to those of us that have followed the enzalutamide story. You see hypertension as you'd expect, you see fatigues, you see increased risk of falls, and so forth. You see a little bit of an increase in cardiovascular events. As we interpret these side effects for both of these studies, it is important to recognize that because of the efficacy side of the equation, patients are on the drug a heck of a lot longer than on the placebo. So the observation period is a lot longer. So some of the differences are just because if you watch somebody for 3 years, you're going to have more events of something in 74-year-old men than if you observe them for a year. And some of it is due to the drug, and one has to take that into consideration as one looks at the data. Adverse effects of special interest, these are things that we pay particular attention to with these drugs. Hypertension, cardiovascular events, 5% versus 3%. Relatively poorly defined mental impairment disorders, and those of us who prescribe this drug a lot, see these kinds of things. They may not be readily measurable with neurocognitive tests, but some patients report that they're not quite as sharp in their concentration and thinking on this drug. Hepatic impairment, very uncommon. It's not really increased over placebo. And seizures, again, extremely rare, as we've seen in other studies. The colors on these curves are a little bit odd on this screen, but you can see MFS very similar to what I showed you for apalutamide. A hazard ratio of 0.29, really nearly identical in both of these studies. Similar message from the forest plot. The treatment effects appear to be consistently observed across all subgroups. Time to the first use of anti-neoplastic therapy, not surprisingly, follows a similar story to the MFS result. Overall survival really not mature, hazard ratio 0.8, not statistically significant at this point. Now, I haven't seen data on time to symptomatic progression, which has been reported for apalutamide. I suspect that's coming. These data are being analyzed as we speak. What we haven't heard from is a third pivotal trial. This is the Aramis trial from Bayer with ODM 201. Very similar design. There are some reasons to believe that ODM may have a little bit less central nervous system penetration than enzalutamide and apalutamide. We don't know how clinically significant that'll turn out to be, but to the extent that the fatigue side effects and the cognitive and fall side effects may have a CNS background, I think we're quite interested in seeing whether or not we'll see any kind of an advantage toxicity with this agent as the trials mature. So in conclusion, for this part of the talk, M0 CRPC or non-metastatic CRPC represents an asymptomatic disease with a variable prognosis, but PSA kinetics can be used quite well to predict risk of metastases and death. Bone-targeted approaches have disappointed in this disease state, but now the high-potency androgen receptor antagonists have clearly demonstrated a delay in metastasis-free survival. In the case of apalutamide, we've got evidence for delaying symptomatic events, trends in favor of overall survival with very immature data. It's quite difficult to distinguish between apalutamide and enzalutamide in terms of efficacy and safety. There might be some subtle toxicity differences, but it's they haven't been compared head to head in a single trial. In practice, this therapy is costly and is being administered to patients who are asymptomatic to begin with. So we have some individual patient judgments to make about when to treat and who to treat versus continued observation in this asymptomatic state with a fairly good prognosis. Another question in my mind is can these patients be treated intermittently? There will be a significant subset of patients that you treat that will have a CR or a near CR by PSA. They may have some fatigue. Could we take a break from therapy? These studies did not ask that question. We don't have any data on that, but I think an opportunity for the cooperative groups to do some studies to help us define further how to practice. And on the flip side, we're seeing fantastic responses. These patients do die from their disease within 3 to 4 years. Is this an opportunity to intensify therapy with something innovative and try to really markedly alter the natural history of this disease and perhaps cure some patients? So I think there's real opportunities to build on these findings and take the field forward. That's the end of this talk, and I guess since we're not taking any questions, I'll